Welcome, everyone, for this exciting opportunity to zoom into a meeting that has been underway the last few days about research during global crisis. This is a collaboration between Sage Publishing's Methodspace.com, which is an online research hub where you'll be able to find the recording for this event, as well as links to related materials. This meeting, it comes at an important time where researchers of all kinds have been challenged by profound problems. And I think it's exciting that we have this opportunity to start to think ahead and understand what responsibilities and what opportunities we have to contribute and perhaps be in a better state when the next big crisis comes along. So for this event, we will start with a short video that introduces the panel. And I would like to note that we have an addition, Catherine Littler, who is the co-lead of the Global Health Ethics and Governance Unit at the WHO headquarters in Geneva. After this short video, the panel will discuss a few key questions, and then we will open it up to respond to your questions. So please take this opportunity to write your questions in the chat area so that we can discuss them. Thank you very much. And Doris, why don't you begin the next stage? Or I think we'll watch the video and then we'll.
Indeed, the video. This is an introduction to the project and the panelists.
And I'm the coordinator of the Prepared project. I'm recording this 3-minute introduction because it will be difficult to speak from the room. The project started on the 1st of September and you are taking part in our kickoff meeting. The project is funded by the European Commission. We have a very strong presence in Europe, of course, but you can also see that we have a strong presence in Asia, Africa, and also colleagues in North America and Australia working with us. The project objective is to develop an ethics and integrity framework to support rapid, effective research during global crisis. We will work in platforms or stakeholder groupings, and these are the groups we currently work with. Our outputs will be an accessible and jargon-free ethics code to be applied during global crisis, how-to guidelines for research teams to support researchers who are working in a global crisis, and engaging training and capacity building materials, which will benefit from the fact that we will have 2 artists working with us. These are our 3 main outputs, but there will be more. I'm very grateful to Janet from Methodspace to make it possible for us to be here with you today virtually. There are around 50 people in the room, and Janet will take questions from online participants, and I will take questions from the floor here. It's a great privilege for me to introduce this panel. We have Professor Charles Weyer, who is Professor of Medicine, Epidemiology, and Biostatistics and Philosophy at Western University in London, Canada. We have Dr. Michael Makanga, the Executive Director of the EDCDB. We have Dr. Joshua Kimani, the Clinical Director of Partners for Health and Development in Africa. We have Joyce Adhiambo, who works with Dr. Kimani as an HIV champion and to support research involving 40,000 sex workers in Nairobi. We have Dorian Karatsas, the Head of Ethics and Integrity at DG Research and Innovation of the European Commission. We have Professor Klaus Leisinger, the President of the Foundation Global Values Alliance and former personal advisor on corporate responsibility to Kofi Annan and Ban Ki-moon. We have Dr. Carly Krugner, who is the bioethics lead for the Wellcome Trust. We have Professor Mariette van den Hoven, who is Professor of Ethics, Law, and Medical Humanities at Amsterdam UMC. And we have Fritz Schmuhl, who is a senior publisher in Springer Nature's Mathematics, Physical and Applied Sciences Journal Division. Very exciting panel, and now I can switch to the room.
Again to Sage Publishing. I hope the sound is okay for the audience, the global audience. And I would now like to pose a question to this fantastic panel. Each panel member will give a statement, and then after the first question, we will pause for questions from the audience and then go to the second part. So the main question, what challenges did you, coming from so many different stakeholder groups, encounter during the COVID-19 pandemic for research?
Yeah, thank you very much, Doris, for this opportunity to say something. So it's about challenges and opportunities, I would say. And I speak from a researcher's perspective, but also as a head of department, seeing other researchers in my department, and I'm also a member of the IRB. So I'd like to combine these things in a few observations. And the first is there was a lot of pressure in IRBs to actually come up with something to do research. There was a sense of urgency, a high sense of urgency. And actually, when I asked my colleagues also in preparation for today, they said, well, there was this tendency to approve also the less well-designed studies because we felt it was needed that we would approve of them as soon as possible. But these were also quite often small scale studies. So that's another thing. We can talk about it later. Many small scale studies were being conducted that led to ultimately not so useful data. Data collection was hugely interrupted for many researchers, also at my department. It required a lot of creativity, working not in the field of the life sciences immediately, but doing a lot of qualitative research. People had to become really creative to collect their data, but for many researchers worldwide, it was completely disrupted. No data could be collected at all. And then not to forget, I think, for many researchers, one of the biggest issues that they confronted with during all these waves was that they had to balance teaching and the private lives, often homeschooling of children, and at the same time also doing some research. Well, what is out of the door the easiest? That's research. So research time really decreased for many people. And we see, especially amongst young parents, and then amongst the group of young parents, especially female researchers, they have really suffered as a consequence. So now, even in a Dutch report that recently was published, they talk about the fear of a lost generation in career-wise as a result of the COVID pandemic, because they could not publish as much as possible as they would have otherwise. So that would be my first initial answer to your question.
Thank you. Joshua?
I speak as a frontline worker and as a manager of a program taking care of 40,000 sex workers in Nairobi, Kenya, and more so in terms of what happened after the government and policymakers in Kenya adopted the control measures for COVID-19. One of the things that happened was there was movement cessation, and people were supposed to work from home. And that kind of caused a lot of disruption in terms of service provision for the marginalized population. People who were supposed to access ARVs couldn't access them. People who were sick with other infections couldn't access the drugs because the clinics were closed. And people who were actually in clinical studies couldn't actually come for their follow-up visits. The other thing that happened was that, and major there was, because of the disruptions and the closure of all the hotspots, and people couldn't meet, then there was a very severe economic crisis among the sex workers because they earn daily wages and they have to go out to actually make money. So not going out to actually meet the clients meant that they can actually not make any money. And that caused a lot of economic issues because they lost their livelihoods. And the issue was when you can't make money, then you become very defranchised. And there were very, very many complaints in terms of people are kind of saying that they'd rather actually die of COVID-19 or of hunger. And that created a lot of problems because when they went out, then the police or the law enforcement agencies kind of clamped on them, and because they didn't have money even to buy the masks. So one, they were actually brutalized. They were also put in quarantine because they were actually contravening the COVID-19 rules, and that actually caused a lot of problems within the particular community. And it's kind of improved in most recent days, but at least they're still suffering because we've not even recovered fully. And that kind of caused a lot of problems in terms of programming. And I'm hoping that at least within this program, we'll be able to address those issues in terms of how to manage emerging crises in a better way. Thank you.
Yes, so the research clinics where Joshua is working as a clinical director and provides antiretroviral HIV medications to people like me, actually got a big hit because most of the clinics were closed down. And then the research participants who are in the research during that COVID pandemic could not engage in the research activities because of the adverse effects of the increasing risks of COVID-19 infection. So the underlying conditions of poverty, lack of employment, and poor healthcare systems is in the country, whereby key populations cannot access healthcare services because of the lockdowns and cessation of movements, actually was a big bang to the community members. So some of the sex workers clearly indicated that they cannot participate in the COVID vaccine activities, for example, vaccination or even COVID vaccine tests, because of fear of being isolated or being stigmatized or being discriminated from other parts of the community. So I think it's high time the government should start thinking about the most vulnerable populations, the key populations, and even the marginalized populations.
Thank you very much. Lauren?
I guess the biggest challenge that we had was to define what prepared is. We thought that after Zika and after the first SARS crisis, and having evaluated many proposals that come for European Commission funding, having drafted internal guidelines, we would be prepared. But I think it's very difficult to be prepared for the massive impact that we had this time around. The biggest problem, and I'm speaking from the side of the ethics review committees. The biggest problem that we had, at least at the European Commission level, is having access to expertise. There was such a high demand for expertise at different levels of the response, at the research level, at the field level, at the relations with the stakeholders, communities, patients, public health authorities. Of course, at the level of advising the government, that it was not very easy to find experts to review the massive amount of proposals that we received at the EC level to finance for COVID. The second challenge was that although we thought we were prepared for a faster acting ethics review board, having had the experience of the previous crisis, including in social research, such as the African Spring and the Arab Spring, and also the crisis with the migration/refugee issues that we had in Europe. It is difficult to change the mentality sometimes of the ethics review boards that like and should operate slowly. They should examine the issues analytically. They should try to make the life of the researcher as easy as possible without presenting ethics as a red tape mechanism. This mental switch from speeding up while keeping exactly the same conditions of quality has been a very, very difficult shift. And I am lucky because I work in an institution that provided for the resources to facilitate this mental shift. If you see at the reviews of most of the meta reviews of most of the lessons learned, you will see that one of the issues that come again and again from all over the world is the support to the ethics review boards and in order for them to perform their tasks. I think this is a major challenge, and I think both projects that we will be discussing in the future, Prepare and IREX, will work a long way to have this preparedness from the support point of view and from the expertise point of view for research ethics committees. Thank you.
And we now go to our remote colleague in Canada first, and then we go to Geneva. Charles first.
Well, thanks very much. I think the desire to speed research progress during the pandemic, it runs the risk of compromising both the methodological rigor and the ethical integrity of research. In the first 6 months of the COVID-19 pandemic, we saw over 1,300 clinical trials registered. But 2/3 of these trials plan to recruit patients at a single center, putting that trial at risk of recruitment failure. Further methodological flaws in these studies were apparent. For example, only 53% of those trials reported no plans at all for blinding. How many of these registered trials were completed? Well, 1 year later, in June 2021, only 69 published randomized controlled trials of COVID-19 therapeutics could be identified. And of these, half had high risk of bias, implying that the results were unreliable. Indeed, unreliable trial results of COVID-19 therapeutics likely led to patients receiving ineffective or harmful treatment. In one well-known instance, a meta-analysis concluded that ivermectin, a drug used to treat parasitic diseases, was associated with a large survival benefit for COVID-19. But a reanalysis by the study authors subsequently showed that this positive result was dependent, in fact, entirely dependent, on the inclusion of studies with a high risk of bias or potential medical fraud. Thus, the imperative to accelerate science during the pandemic resulted in considerable research waste, meaning that patients were exposed to the burdens of research participation without the prospect of social and scientific value. Thanks.
Thank you very much. And now over to the World Health Organization in Geneva and Catherine Littler.
Thank you very much. It's hard to consolidate one's thoughts in a short period of time, but I'll pick up on some of the issues that have already been mentioned. The first one I want to start with is, I think, a challenge for the ethics community, full stop. And I think we have a translation problem. So at the beginning, we looked at WHO colleagues, we looked at when we established the ethics working group as part of the R&D blueprint, all the guidance that was out there. And there is a lot of guidance that existed on the back of SARS, H1N1, Lassa, Ebola, Zika. So it wasn't that we didn't have the pre-existing guidance. It was that that guidance is not being translated into policy and action. So I think going forward, initiatives such as Prepared and work that we're doing at the WHO really has to focus on that interface between how do we make sure that the work that we're dealing with actually gets translated into policy. We've heard about solidarity, equity, all being frontline, but have we gone in the right direction in terms of global health justice? Arguably no. Second, I want to raise the equity issue. It's been front and center in terms of access to vaccines. We have had successes in terms of research, but the access hasn't flowed through. But I think the problem is the focus on the equity at the end of the process and not equity at the beginning of the process, of the research process. And that flows all the way through from coordination, collaboration, governance to networks. So, and in terms of equity and access, I'd like to make a question, follow up on the issue on ethics review boards. I agree that ethics review has to change from policing to enabling. And we have to adapt. We have to adapt for new models. And there's some really great examples of development of standard operating procedures at the national level, and people are able to move quickly. But I think we also need to make a strong case for investment in ethics oversight. There are many cases of burnout and people not having the capacity to do that. So I think it's really on us to start making arguments for that. I want to make a point about networks as well. I was saying about equity in networks. At the beginning of the pandemic, we set up a network, the Epidemic Ethics Network. This is on the back of work from past networks, noticing that a lot of the ethics advice is not contextual ethics advice. And I think that is critically important, both for response, but also building into research that is appropriate in different settings. And finally, this contextual ethics advice that I was talking about, that really needs to be front and center. We have great examples on the back of Charles's talking about wastage. We have some really good examples of adaptive and new trial designs, predominantly still coming out of, if you look at recovery and remap cap, coming out of high income countries. We need to change that. They are starting to change that. So really that equity has to flow through into the research design, and we need to really concentrate on redundant. How do we prevent redundant trials? What's the role of ethics research committees in that, and what's the role of us in that? And I'll stop there. Thank you.
Thank you very much, Catherine. And now we go back to the room with Michael Mukanga.
Thank you very much, Doris. From the research funders' perspective, COVID-19 really got us at a time when we had a lot of activities running. On our side, we're working with 44 African countries and 19 European countries involved in multiple highly collaborative research. And this is involving individuals that are normally marginalized. We are talking about maternal and child health, individuals with co-infections and comorbidities. And this is research work that is being conducted in low and middle income countries. Now, the very well-intended COVID-19 control measures had serious disruptions, especially on the clinical research activities, where follow-up in studies that already had interventions rolled out was very, very difficult. And this is at a time when, as you recall, on the side of high-income countries, all countries called back their infectious disease experts. The national countries also had their highly skilled workers involved in multiple activities. So there was limited manpower, limited transport, and clinics were not operational. So it made follow-up of patients very challenging. And in this would have compromised the safety of individuals. But thanks to the solutions, creative solutions that were enabled by digital technologies, and also the massive effort we had made to invest in local infrastructure and capacity development of experts. With this, we're able to minimize the potential damage that would have been caused on the ethical and legal implications on patients that are enrolled in clinical trials.
Thank you very much.
Yeah, so picking up on a number of the topics that have already been mentioned by other panelists, I'm going to talk a little bit about the rapid acceleration of the R&D pipeline and an issue that hasn't yet been raised, which is that while it was great to move fast with some of the caveats that have been raised and some of the pitfalls, we also weren't as attentive as we could have been to certain complex research populations, such as pregnant persons, children, people with underlying conditions, to make sure that we also produced data that would be attached to their needs, that we had recommendations ready to be able to roll out vaccines and therapeutics in ways that they could feel confident in. So that's one major issue. Another pertains to the public perception around that accelerated timeline. And I think the broader failure to effectively communicate both the science and the rationale, and the fact that corners were not necessarily cut to produce some of those interventions. And we saw that there was huge implications on confidence of those interventions because we didn't effectively communicate. So I think we need to be much better about translating science and also scientific uncertainty as the science is evolving, as we build up the evidence base to make recommendations, and making sure that the public comes along for that ride. As many have mentioned, I think there were really challenging issues around data collection, and not just going out and collecting data, but even relying on some of those vital statistics systems, some of the things that were the routine data collection systems, particularly as we think about the research to policy pipeline. We're trying to do a lot of work to use rapid evidence to feed into policy decisions, And we just didn't have the resources there because people couldn't go out and collect the data. The systems that had been in place prior just weren't there because we weren't getting that data put into the system to feed to policy in real time. And at the risk of some duplication, the duplication of research. I think everybody sort of pivoted to turn to COVID and try and provide resources and evidence. But we did see a lot of duplicative research efforts where we could have had much more coordination, either larger multi-site trials, and just avoided wastage of funding that could have been directed to gaps that were underattended to in the context of COVID research. So I'll stop there.
As a publisher, we in the peculiar position that we operate very much at the end of the research cycle, which means we get research outcomes, the task being to get that through review and then disseminate that, but not to effect any modifications in that. This is complete research. We publish it. That's that. The task in that is then mainly to focus on the peer review process to ensure that scientific integrity can be ensured throughout that. It actually starts a little bit earlier from the submission process through peer review to publication and post-publication. So to a certain degree, the pandemic didn't change that much for publishers because at the end of the day, the task still very much is to introduce rigor at a requisite level throughout the process. What did change, though, was the sheer volume of submissions we got actually through a remarkable number of disciplines, not only the disciplines one would expect. So by no means only on the clinical side. Strangest disciplines contributed hugely to the vast increase on COVID-19 content. At the best of times, the peer review process is subjected to a lot of pressures. The fact that we are in whatever discipline fishing in a decidedly small pool of reviewers, the lack of time that reviewers have at their disposal, and then also the pressure put on authors in the eternal publishing parish system to get their content out as quickly as possible. And then particularly if we look at some fields where first publication is of key importance to further careers, to get funding, all of those pressures increased vastly during the pandemic and were brought to bear pretty much largely on the peer review process. That created pressures upstream and downstream. For peer reviewers, there was the very much shared in the sense of urgency that they had an obligation to take content, to have that reviewed and get it published as quickly as possible so that there's a beneficial outcome at the end. So there already the pressure, and that was sometimes self-applied pressure, sometimes externally, already there the pressure was very great. The pressure also came from authors who in many cases correctly indicated that there is a great need that their research should get preference in peer review, get published. Add that to a creaking system already, and that means that there's quickly a shift towards skipping some steps. One of the things we saw that there was on the side of authors, sometimes on the side of peer reviewers, when it came to data presented, a view that we should have an approach of this being good enough. Of course, from a point of view of data sets being big enough or not, methodological issues, that immediately creates the kind of pressures that some other panelists had already indicated happened in the clinical trials. So that immediately was a point where the scientific integrity that we have an obligation as a publisher to ensure in the process, that there was a danger that that would be undermined greatly. Keep it to that.
Okay, what were the difficulties I encountered as a kind of an impartial spectator on this. It seemed to me that under pressure, under time pressure, and also under resource pressure, people forget good management practices and ethical values. To be more concrete, it is about not only to collect data, but share them with stakeholders that need them, because it's a pandemic and not an epidemic. And do joint evaluations, analyze and recommend without a hidden agenda. I had the impression that a lot of information went out with a clearly visible hidden agenda. And that caused confidence and trust. And this is exactly what we need in such a complex situation. Communicate in terms that people will understand. Sometimes things do not develop the way we would expect them, but then explain why, communicate why, because otherwise people come up with their own explanations. Apply transparent values and comply with them. And here I would say, be careful in what you promise, under-promise, over-deliver. Be transparent about the legitimate interests that are involved. There are no disinterested parties on this world. And last but not least, context matters here, of course, as well. If I listen to Joyce or if I listen to others, things that might be appropriate in OECD countries might not be appropriate at all in a low-income environment. And if we do not, adapt contextualizing ethics, we might meaning well, but not doing well. If these things are not considered, we will not find sustainable solutions, but we will have a trickle up of benefits, and that again will cost a lot of trust.
Thank you very much. This was the panel responding to question 1. I would now like to hand over to Janet in case there are questions from the audience.
I would encourage our audience members to post your questions either to specific panelists or to the panel as a whole. But I'd like to start by one of the themes that I've heard from you about the balance needed between speed and rigor and methodological soundness in design, and ask you what recommendations have come out of your meetings so far that might help universities and others who are trying to prepare ethics and IRB review board members or peer review members to better scrutinize, especially as we look at kind of greater complexity and multidisciplinary kinds of proposals that are needed to address the kinds of problems that we have today. So, what practical or kind of big ideas have come out of your meetings so far, around ways to address those issues?
Thank you very much, Janet. We're the kickoff meeting, which means it's the first time that we're all together. So we're currently collecting ideas, but I'm not sure whether a big one has emerged for recording. But let me ask the panel, including Catherine and Charles, whether we already have big ideas too on this very complex question that Janet has asked.
Can I start? Yeah. Can I start? Yeah. So also consulting my other IRB members, they said, well, overall, they also did a study in the Netherlands. If the quality standards were seriously dropped and the results were promising, that most of the committee members felt that they kept up to high standards, but it was mainly at the beginning of the pandemic that it really became an issue. Why? Because the nature of the meetings changed. So there were online meetings now, and you had completely different type of interaction, which made the ethicists particularly feel that ethics became a single expertise, not something that all members of the committee were responsible for, but the ethical expert would get the floor and then bring forward 1 or 2 issues, and that it had to fight against other positions that were also orderly presented, and there was no discussion any longer. So that made them feel, and at some points they really had to also really firmly pointed out that ethical aspects are integrated into all the considerations that an IRB has to make. It's not methodology or research ethics, it's methodology and research. All these considerations about informed consent, risks, etc., they are all intertwined. And that feeling was a bit lost in the beginning. So.
Catherine, is that a hand?
Yeah, sorry, I'm slow on the uptake. I was trying to find the button again. So I think a couple of things are coming on the back of COVID, but actually these existed, I think, when people were mopping up after the West African Ebola outbreak. And a few of them are the pre-approved protocols. I think that's an idea that we should invest in more. Of course, they need to come back to an ethics committee for some of the changes, and they'll need to go back to local ethics committees. Better communication between ethics committees at differing levels, national, local, global. I run a global ethics committee. And then in terms of even things as basic as having pre-prepared standard operating procedures for how you operate in a pandemic and what are your turnaround timelines, they have made a huge difference. And I think countries, from example, the Pan American Health Organization, our sister organization, PAHO, did really well on the back of Zika. They did put in place at the national level some of these. So I think there's some of the things we can start to learn from in terms of that challenge with speed and also rigor and better training. We're doing a whole piece of work around the oversight of adaptive trial designs. I think we need to rethink our oversight models to make allowance for those. Do we need to have an ethicist on a DSMB? So I think rethinking and adapting is something that we really need to be, and thinking out of the box would be my other comments, and I'll leave it there.
Thank you very much. And we've got Charles and then Michael and Dorian. So your question sparked a lot, Janet. Thank you. Charles.
I think one of the major changes we saw in the conduct of research was actually the impact on clinical trials outside of COVID-19. Of course, thousands of trials involving hundreds of thousands of patients globally were interrupted, put on hold with the pandemic. And we saw a shift to decentralized trials, right? So trials that were now, rather than recruiting in person, we're recruiting people remotely over Zoom chats who were delivering medications to people's homes, having people fill out questionnaires remotely. And I think one of the challenges we face moving forward is for actually research ethics to kind of catch up to some of the ethical issues raised by that. How do we conduct consent sort of appropriately when that consent is obtained remotely? Do we need to worry more about sort of subtle cognitive incapacities being missed in remote interactions? And crucially, what is the impact of decentralized trials on equity in clinical trials? On the one hand, it seems to present some opportunities in terms of making trials more accessible for some populations, including perhaps rural populations. But on the other hand, we might sort of worry about equity and access to internet and smart devices and so on. So a lot of challenges for us in research ethics moving forward.
Thank you very much. In the room, we have Michael Makanga.
Thank you very much. A quick comment on the balance between speed and maintenance of rigor in a situation where you have novel designs and increasing complexity of studies. One good experience that has been helpful is for national ethics committees, and this also relates to national regulatory authorities, sharing experiences and having joint reviews, some of which can be done remotely, to really discuss the complex issues, and especially this when it comes to multi-country, multi-center studies that have the same study protocols, while giving the individual countries their sovereignty to look at the local context and address them when they finish doing the joint reviews. Just wanted to share that.
Thank you. And to Dorian now.
Yes, it is true that a lot of great work has been done. PAHO in Latin America has published a beautiful review, and you can see the different efforts that they have made to address issues of informed consent, etc. The European level, we learn how to trust the local committees a lot more. Allow them to do their work without our over presence, in a sense. Allow them to do their work in rigor and speed. But from our side, we started focusing a lot on monitoring and what we call ethics checks. Do not leave the researchers alone or the research teams once you got the ethics approval. Be with them, follow them, be advisors in their work, in their issues that are raised that cannot necessarily be answered directly by a sometimes compliance process. So follow-up, advice, and expertise within the teams while the work is going on. Thanks.
Thank you. Do we have any questions in the room here? Yeah. I need to repeat your question for the microphone.
What are some of the tangible effects that losing people in a clinical trial or losing follow-up has on the research itself? Like, what does it actually mean when you lose people in the trial? Like, how does that impact what you're trying to figure out?
So the question from the room was, what is the exact impact or the tangible impact of losing people from trials?
The quick answer is the validity of the results of the trial, because the sample size becomes smaller and you have fewer responses than were actually expected.
Yes, just to add on to this, at the beginning of a trial, you have a sample size that is defined, and you also have an allowance that with this sample size, we allow for this loss to follow up. And this affects the analysis and being able to interpret your results. So you want to minimize and to keep within what you set at the very beginning. Otherwise, you have to redefine your endpoints, and that again brings a question to the validity of the results.
Charles, do you have anything to add? You've raised your hand.
Yes, just briefly, I agree that power is an issue here, but I think we need to remember that bias is also an issue. So if people are, so the crucial question is, why are we losing people to follow up? And if people are dropping out or we're losing them for other reasons related to the intervention, right, that could bias our findings in important ways.
Janet, do you have more questions from the audience? Or shall I ask the room?
We do not. So why don't you go to the next question you
yes.
laid out?
The next question, and I'm not even sure we're able to go through all of the panel, but it's the question of how can stakeholders collaborate better in the future? So, or perhaps we could have 2 sentences from each in the room and only then move to remote. And this time we start from Klaus, who's flexible enough for this.
Shall I start?
Yeah.
Okay. From my experience, it's all about trust, particularly if we are working in risky areas. New avenues are still associated with risk. Particularly then, you must create as much trust as you possibly can, because as long as everything goes fine, that's okay. But if something goes wrong, it is very important that people trust each other, because then you can evaluate and go forward. So that means be also communicate not only on the successes you have, communicate also on the problems you face. And if there are problems and if they can be explained by other arguments like bad will, then people will understand and also be more patient. The second thing is communicate about your interests and about your values. Say what is important to you. and get the message over. I have respect for your values and for your interests. Please have respect for my values and for my interests. And last but not least, concentrate on what you have in common, not what separates you. And if you start your work on what you have in common, you can build up the mutual trust that allows you to go into areas where you do not have the same interests and the same values.
Thank you.
Editorial policies in journals are defined contrary to what one might think, only to a very small part by publishers themselves. Those are more on the operational side than anything else. For the very large part, editorial policies are in fact informed by, shaped by the entire research process. One thing that struck me during the pandemic is that publishers do that on a fairly reactive basis. That is the outcome of the process. But the comments that I heard today on clinical trials, how scientific rigor can be ensured much more there, leads me to think that much can be gained from starting at a much earlier process in working with ethical teams, with especially on how clinical trials are designed to reflect, to mirror what we do on the publishing side with editorial policies.
Yeah, so I think the value can't be understated of having existing networks, platforms, cross-disciplinary mechanisms to facilitate communication ahead of new outbreaks, ahead of new crises, so that way, when you're in crisis mode, you're not trying to start something new and bespoke. You already have the infrastructure in place for people to rapidly coordinate and facilitate responses. Similarly, I think having existing relationships between researchers and policymakers to facilitate that evidence to policy translation, and investing in effective science communication, trusted knowledge brokers who maybe are outside of some of the more hairy political segments is just going to be really essential to reach the public with the right messaging from a trusted knowledge broker. And the last one is really about the relationships between funders as well as researcher networks, just to do more coordination around what types of research investments are coming down the pipeline, avoiding duplication and trying to link up any complementary research efforts and endeavors. Thank you.
Thank you. And here it's also on the side of the balance between expectations and what really happens. On the side of the research funders, there is need for more cooperation, cooperating to ensure that there is compliance to the available global set of standards and good practices, but also recognizing that things that are set up during a time of crisis, this is the time when countries, institutions, and individuals are in a rapid response mode, and they tend not to comply. But things that are set up during the peaceful times, and this speaks to real preparedness, they tend to have more buy-in of stakeholders and acceptability. And I'm hoping that the prepared initiative will play a role here during this relatively peaceful time to really have a contribution to the ethics and integrity gap. Thank you.
And indeed, preparedness and trust are related, and they are not built only during crisis. They are built long before a crisis starts in order for trust to be really having an effect. I remember the lessons learned of the Foot and Mouth Committee in 2001. Their first recommendation was implement the lessons learned from the mad cow disease crisis in 1996. And we are very bad at doing this. And this is something that we have to improve, but we also have to realize that there is so much, and I'm only speaking from the side of the ethics committee and the ethics community, there is that much that the ethics community can do. But what the ethics community can do through projects like PREPARE, through projects like IREX, is stimulate the discussion higher up. Continue, if at all possible, efforts for the decision makers and the policy makers to be aware of the discussion, to be aware of the lessons, to be aware of the options that they have. Because after all, ethics is all about giving the right options also to decision makers.
Joyce?
I think upholding the ethics standards of operational procedures and then effective communications, even when there are disasters or pandemics.
For me, I think it's mainly kind of improving communication, meaningfully engaging all the stakeholders and trying to kind of come up with something uniform, and that would actually cut across between all the stakeholders involved in the activity that is at hand.
Yeah, thank you. So Klaus started with trust, and I would like to add transparency. I think that, well, given the fact that it was 2020 that this crisis occurred, we've learned already that there was a lot more to share on the internet, and that we could also online communicate, but still we have many lessons to learn. Transparency is not about just sharing about anything, but because in the preprints bulk that we've seen, a lot of rubbish was also shared with others. So yeah, maybe, I hope, that's more a wish, I would say, that we will actually learn to change our default research behavior, because I think that's the only guarantee that in the future we will actually be more resilient towards crisis, because upholding ethical standards when they are not really implemented or not really internal to research behavior, that's really difficult, I think, in times of crisis.
Thank you. And now we go from the floor to the remote speakers. First to Catherine, and Charles can conclude. Catherine?
So really, I think the only thing I would have to add is I think we have to be honest about the engagement isn't an exact science, and we're still on a learning curve. So I would say it's key that we explore models of stakeholder engagement going forward. And secondly, we're very clear about the purpose of our engagement and where we are in the process. Not all engagement will or should feed into decision making, but we need to be honest and upfront about why we're doing the engagement. But yeah, and also that we've got a lot to learn.
Thank you very much. And Charles?
Thanks. So I think a number of people, including Catherine, made the point about the importance of pre-approved protocols and getting organized around that before the next pandemic. And I think that's exactly right. The idea that single center studies are going to be useful here, I think there's clearly now an experience that that's not the way to go. So we need to invest now in the infrastructure to conduct multi-center platform trials in the future. So I think that's a really important piece of this. I think more broadly, I think it would be prudent to require that clinical trials each have an identified biostatistician that they're working with, simply because of the problem of research waste. And finally, others have made this point, but I want to highlight it, that in a sense, when a trial comes to research ethics committee review, it's a bit late. And we would do better to provide access to research ethics advice to researchers at the time of protocol development.
Yes.
Thank you very much. We now have 5 minutes left. Janet, can I just check whether I can ask for questions in the room, or do you have questions online? You're muted, I think.
We have one question about monitoring and oversight, which several people have mentioned, given that many projects are of short duration, or particularly during this time that there were, so how, what suggestions do you have, for really carrying out that kind of presence and oversight, especially when there might be multiple research centers involved, but short duration?
We have a person here who runs the monitoring, the ethics monitoring for all of the European Commission's funding. So perhaps it's for you. Do you have any advice?
Come, let's
Plan ahead. There is and try to work because not always the budget for monitoring will be available. I think we have to be very smart at implementing a system that does not tax research at a high rate. We have to be able to do that, and we are trying to do that to the degree that at least for European Commission funding, if your proposal comes already with a proposal to have an ethics advisor built in, is reimbursed by the Commission. So it's an additional funding that comes for research. I know this is a luxury that many places cannot afford, but what we hope to achieve also is that through the presence of the advisors and the monitoring, you do not have a continuation of a compliance mechanism, but you have a discussion, an exchange. So ethics is not there to resolve problems always, but ethics is also there to anticipate and to educate and to train.
And this aligns with Charles' suggestion to bring in the ethicists earlier.
Yes, that's what we do.
Is there a question in the room? Yep. This is Rafaela Ravinetto, the chair of the Médecins Sans Frontières Ethics Committee.
Yeah, we were talking about clinical trials. There are a number of very good ethics guidelines, but many sponsors, researchers, and also ethics committee mainly refers to the ICH GCP guidelines. And we were talking about trust, which is indeed essential, but the ICH GCP guidelines do not even mention communities and patients as stakeholders in research. So where do we go from here? Because I feel this lack in these international guidelines really creates a problem, and the communities are often left behind.
You probably didn't get this in the online community. Rafaela mentioned that the guidelines don't even mention, often ethics guidelines don't even mention community engagement and creating trust. So where do we go from this point where we have guidelines, ethics guidelines that don't even take community engagement into consideration?
ICH
GCP.
Yes, the ICH GCP. The good clinical practice doesn't even talk about engagement. They should then.
Yes. That's it.
That's the answer.
Will be one of the first sets that I would say ignore these guidelines. add.
Right. So that was easy. Do we have another more?
Yes.
Michael?
Just to add that this is the time also to look at complementary resources. Like the WHO has invested in good practices on good participatory practice, which really involve a lot of the research trials that are done during emergency situations. And the Prepared initiative can also advocate for this and really come up with ways that bring out or draws in the various good practices to have some recommendations around this.
I think that's a very good way for us to conclude from the room here. I would now like to thank Janet again for hosting us, and the last minute is for you.
Well, thank you for allowing us to zoom into your meeting. And I think you've raised some important topics that I think we'll try to follow up on with post to Methodspace, and welcome any resources the panelists want to share that we can make available to our viewers. Many of our readers are, people who are teaching and preparing, guiding the future researchers. And I think some of the points that you've made, are ones that, I hope, they will be able to take up and begin to build into the work that they do. Some of the threads about methodological soundness, rigor, and community engagement and equity oversight, are ones that I hope that, future researchers will, begin to kind of internalize and put into, you look for ways to put into place, whether they are doing, research large or small. So I'd just like to, thank all of the panelists again for so many, useful points and perspectives, and wish you the best as you move forward with the prepared project. Thank you.